Hi guys, now this topic of discussion is going to be on molar pregnancy. When we talk about molar pregnancy, you need to first know about the gestational trophoblastic diseases because the molar pregnancy belongs to this group. So gestational trophoblastic diseases are a group of tumors, group of tumors which are characterized by abnormal trophoblastic proliferation. Just understand in basic point, gestational trophoblastic diseases are a group of tumors which are characterized by abnormal trophoblastic proliferation. So how do we classify this? This is again classified into two groups. That is your Hydatidiform mole and your non-molar trophoblastic diseases. It is classified again as Hydatidiform mole, that is the molar pregnancy, and the non-molar trophoblastic diseases. Under Hydatidiform mole, sub-classification, you have types like complete mole, partial mole, and invasive mole. Under non-molar trophoblastic diseases, you have choriocarcinoma, placental site trophoblastic tumors, and epithelioid trophoblastic tumors. And so we are saying tumors as you know can be benign and malignant. These two types, the complete mole and the partial mole, are benign in nature. The remaining, that is the invasive mole plus the non-molar trophoblastic diseases, these are gestational trophoblastic diseases with a malignant sequelae. So they can be again put into another group of diseases called as gestational. They can be put again into a group called as gestational trophoblastic neoplasia. So these are the two ways of classifying it. So this Hydatidiform mole and non-molar trophoblastic diseases is the classification as per the pathology, right? This is a molar and this is a non-molar. And the pathology depending upon the benign and the malignant is like this. The complete and the partial mole form the benign diseases, whereas the invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor, these comprise the diseases with a malignant sequelae, so they are referred as gestational trophoblastic neoplasia. This topic is going to be only related to the molar pregnancy, that is your Hydatidiform mole. Just a quick recap on the embryology. We are going to be talking about the trophoblastic cells. So what is this trophoblast? If you remember, it is a embryonic cell. It is your embryonic cell. You have to get back to your embryology. So if it is that cell which gives rise to the placenta and the membranes. So you know, after fertilization you have the formation of a morula which forms the blastula, which again goes to form the blastocyst, and this blastocyst further differentiates into inner cell mass and outer cell mass. Inner cell mass is what gives rise to the embryo, whereas the outer cell mass, and that is what is referred to as the trophoblast, that gives rise to your placenta and membranes. And there are two types of trophoblastic cysts, that is your cytotrophoblast and syncytiotrophoblast. Okay. What is the function of this trophoblastic cells ultimately? So once they give rise to the placenta and membranes, so it is like the functions of the placenta and membranes, that is invasion meaning they establish the uteroplacental circulation, so helping in the nutrition, and the production of hormones for the maintenance of pregnancy, like your beta HCG, right? So it is the syncytial trophoblast which gives rise to the beta HCG, whereas it is the cytotrophoblastic cells which gives rise to the chorion. Chorion is your placental membrane, one of your fetal membranes, and it also gives, it has a important function of prevention of PIH, your pregnancy induced hypertension. This is just a small recap on trophoblasts. So coming back to the topic, Hydatidiform mole. Okay, please remember that this is a pregnancy, right? So it is an abnormal pregnancy, just mug up this line, which is characterized by hydropic degeneration and avascularity of the chorionic villi and the trophoblastic proliferation. I repeat, it is an abnormal pregnancy which is characterized by hydropic degeneration and avascularity of the chorionic villi and trophoblastic proliferation. So, due to which the resultant conceptus is a grape-like vesicles called moles. Okay, the resultant conceptus is grape-like vesicles called as moles, and like I told you before, this is regarded as a benign neoplasm of the chorion, right, the fetal membrane, but with the malignant potential. Okay, also like I've been saying, these will form a group of tumors. So this is benign, but it still can have a malignant potential. And the types of Hydatidiform mole are complete moles, partial moles, and invasive mole. Now invasive mole. The epidemiology and incidence, there is seen to be noted an ethnic predisposition in terms of the incidence of Hydatidiform mole, with maximum incidence in Asian and Oriental countries like Chinese, Japanese, Philippines and Indonesia. So one of the maximum incidence is seen in Philippines with 1:40 incidence. In India it is around 1 in 400. Women who are on the extremes of age, like in teenage pregnancies, and women in older age groups like more than 35-40 years of groups, are seen to have an increased incidence of molar pregnancies. Very important risk factor is a history of a prior Hydatidiform mole. If there is a history of a prior Hydatidiform mole, gives an increased risk for them in the future to further develop molar pregnancies. Faulty diet. Well, folic acid deficiency has seen to be associated with molar pregnancy. This is an MCQ. And some unexplained disturbed maternal immune mechanisms are also involved. And another point is women with blood group A positive are also seen to be at a risk for developing a molar pregnancy, not known exactly why. Pathogenesis. This is one concept which you need to understand so that you can further understand molar pregnancy. That is that the main pathogenesis of this molar pregnancy is that it arises from a chromosomally abnormal fertilization, right? Chromosomally abnormal fertilization. And the resultant concept, like we already mentioned, it is the formation of these grape-like cystic vesicles, which we call as moles. It can fill up the entire uterine cavity and form this molar pregnancy. Now we will discuss each types in detail. Complete mole. What is this complete mole? In complete mole, this degeneration and the swelling of the villi and the trophoblastic proliferation, it involves the entire villus. Okay, complete mole, the pathology, the abnormal fertilization results in the hydropic degeneration and swelling of the and avascularity of the chorionic villi for the entire villus stroma, and there will be complete absence of blood vessels and there is no evidence of fetal tissue at all. What is the chromosomal abnormality that happens? Okay, so you have, you all know fertilization occurs when a sperm meets an ova and there is zygote formation. So in a complete mole, what happens is you have an ovum but it is inactivated. Okay, that means it is empty. meaning there is no genetic material, no active genetic material in this ova. So when such an ova is fertilized by a sperm, you know the genetic material, sperms, they are haploid in nature, right? So 23X, this will be the karyotype of a sperm. So when this empty ovum is fertilized by a sperm, the further process of fertilization and the cell duplication anyway occurs. But what happens is, when the cell duplication happens, it is the genetic material of the sperm which duplicates, since the ovum is empty. So upon the genetic material of the sperm duplicating, the resultant karyotype will be 46XX. That is, it is a diploid karyotype. Okay, remember this, it is a diploid karyotype. So further cell division occurs with the diploidy karyotype, and this extra genetic material, or rather the entire genetic material of this resulting cells upon daughter cells is totally paternal origin, and so this process is known as androgenesis. Okay, and the most common type is a karyotype of 46XX. Sometimes 46XY is also noted, but in a 46XY, what happens is you have this empty ovum, which is fertilized by two sperms. Okay, it is fertilized by two sperms, and that is giving you the diploidy of 46XY. Okay, but most commonly 85% of the times it is the monospermic fertilization with 46XX as the diploid karyotype. Less commonly it is 15% it is, less commonly it is 46XY. 46YY is not very commonly observed. Okay, so the important questions which will be asked in with regard to complete mole is, there's a few important points. One, it is a diploidy karyotype. Okay, because of it is a monospermic, right? It is a single sperm. It is a monospermic fertilization. The duplication of the spermatic genetic material itself by itself is known. The process is known as androgenesis, and the genetic material is totally paternal in origin. Okay, these are the important 4 points to understand about the complete mole. Partial mole. In partial mole, this enlargement and edema of the villi and the trophoblastic proliferation are slight and focal. Okay, that is why it is known as a partial mole, because the enlargement and edema of the villi and this trophoblastic proliferation is only focal. It is happening in only one area of the pregnancy. So and hence there will be presence of some fetal tissue in a partial mole. Now, what is the abnormal chromosomal abnormal fertilization that happens is, in a partial mole you have a normal ovum. Okay, not empty ovum, a normal ovum with its genetic material, haploid genetic material, but this is fertilized by two sperms, two haploid sperms, and hence upon duplication, upon further fertilization, you have the 23X, 23X, 23X getting fertilized together, this resulting in a 69XXX. This is triploid karyotype. Okay, and the extra genetic material, right? There are 3 copies of genetic material in this, that is why it is known as a triploid, and this extra genetic material is of paternal origin. The extra genetic material is of paternal origin. Okay, so the important points to note here is, partial mole is triploid in nature, it is dispermic, okay, and the extra genetic material is of paternal in origin, and due to this triploidy nature, usually partial mole, like we said, there will be presence of fetal tissue, though the fetal tissue will be, the fetus will be having features like IUGR, it will be having features like it will have some malformations, and it usually dies early. Coming to the clinical features. Since it is a pregnancy, patient is going to have amenorrhea of varying duration, right? And since it is an abnormal pregnancy, it will be followed by irregular vaginal bleeding. 90% of the time, this is the commonest scenario with which the patient is going to present. Okay, it will again most commonly be a first trimester bleed itself. Okay, amenorrhea followed by a vaginal bleeding. Most common presentation is like this. If suppose some patients may give history of passage of the molar tissue itself per vagina, right? They may have history of passing of the molar itself. They may come and say, I'm passing some abnormal thing like this thing. So that is ultimately pathognomonic of a molar pregnancy. Some patients may have abdominal pain because, like I said, this grape-like vesicles is going to be inside. It is going to distend the uterine cavity. It may have the patient may have abdominal pain. Then hyperemesis. So what did we say? Trophoblastic cells are responsible for production of the pregnancy hormone like your beta HCG, right? So when there is abnormal trophoblastic proliferation in these molar pregnancies, there is abnormally increased levels of serum beta HCG, and this increase in this abnormally increase in rise in the serum beta HCG levels results in the patient having hyperemesis, right? The patient may come to you looking very sick, having several episodes of nausea, vomiting, right? A severe grade of hyperemesis, all due to the abnormally raised serum beta HCG levels in the molar pregnancy. And upon examination, the uterine size will be seen to be larger than the period of gestation. Obviously, there will be absence of fetal parts and fetal heart sounds. There may be abdominal distension due to theca lutein cysts. Again, this is another associated feature. Like I said, there is abnormal rise in the serum beta HCG. The hormone HCG has two units actually, alpha and beta. So the alpha subunit of this HCG is similar to your luteinizing hormone LH, follicle stimulating hormone FSH, and TSH. Okay. Due to this, they'll have additional effect like similar to the LH hormone on these theca lutein cysts. Theca lutein cysts are normally formed in the ovary as a part of your menstrual cycles and all that, and they are actually under the influence of the LH hormone. So due to this abnormally raised HCG and due to its similarity to the LH, it will go and stimulate the theca lutein cysts, causing their enlargement. And it can be so enlarged that they can have abdominal distension. They can have thyrotoxicosis because of the similarity to the TSH. So it can go and activate the TSH receptors, leading to a hyperthyroid-like state, causing even thyrotoxicosis. So patient may have features like tachycardia and tremors. Okay. Early onset preeclampsia. Previously, what did I say? One of the functions of this trophoblast was to ensure that there is prevention of PIH. So due to this loss of the function, due to the abnormal proliferation and loss of the function of these trophoblastic cells, the patient may develop an early onset preeclampsia. And respiratory distress can occur due to embolization of the trophoblastic cells. These trophoblastic cells can get embolized, can get entry into the systemic circulation, go into the lungs and cause respiratory distress. Okay, so these are some of the associated features of a molar pregnancy. So if you can have doubts if you see a patient with these kind of symptoms. So the complications, like patient can have complications like hemorrhage. Hemorrhage can be due to the separation of this molar tissue from the decidua. It can be either concealed or it can be revealed, and this can be a severe hemorrhage causing shock to the patient. There can be perforation of the uterus in cases of perforating moles. The moles can penetrate into the myometrium, into the serosa, and ultimately rupture into the abdomen, causing intraperitoneal hemorrhage. Okay, this can be a This can be one complication. And yeah, like I said, pulmonary embolization of the trophoblastic cells causing acute pulmonary insufficiency. Sepsis can occur, and later on they can be a malignant sequelae, because these are benign tumors with a malignant potential. So later on they can give rise to some kind of a malignancy. When you come to the investigations, how do you diagnose it? Okay, because whatever clinical features that we spoke about previously, right, all this amenorrhea, passage of the molar tissue, hyperemesis, the associated thecal cyst enlargement, thyrotoxicosis, respiratory distress, nowadays you don't always see it classically because of the advancement in the ultrasonography and the imaging modalities. These are all seen in the previous times when there was not so much of use of ultrasound. So patient would probably progress for quite some time without knowing that there is a formation of molar pregnancy. They may reach a little advanced gestational age. By then they might have all these kind of associated symptoms, and that is when you probably diagnose a molar pregnancy. But nowadays, due to improvement in the imaging modalities and the radiology life is easier, and you can do an ultrasound and diagnose a molar pregnancy. We call it as a snowstorm appearance when you do an ultrasound. Molar pregnancy, these grape-like cystic vesicles you can see here very clearly, you can make out. Okay, easily you can make out the presence of a complete mole this way, and this appearance upon doing a scan is called as a snowstorm appearance. But a partial mole, like I have previously mentioned before, they will show evidence of fetal tissue, and the molar changes are only focal, right? So when you have a partial mole, as such, upon doing an ultrasound, it may appear as a normal pregnancy, but as a missed abortion, right? You may see that there is some kind of a fetal tissue, the cardiac activity is absent. Okay, so many times a partial mole is confused with a missed abortion, because the changes are only partial. If it is diagnosed in the scan, well and good, but if not, then so ultimately it is the histopathological examination which is the gold standard. Okay, because many times partial mole can be just taken as a missed abortion. Like I said, the fetus is going to have features of triploidy, that is your IUGR, it can die early. So it may not present as a live good pregnancy, it may present as an unhealthy pregnancy with absent cardiac activity. So you think of it as a missed abortion, you treat her for that, but upon doing a histopathology, you may see that it was actually a partial mole. So that can also happen sometimes in cases of partial mole. Serum beta HCG again is used as a very, very important diagnostic modality as well as for the management, because what did we say, that the serum beta HCG levels are abnormally raised in a molar pregnancy. So serum beta HCG also can be measured, and you will see that it will be out of proportion to what you normally see for the for that corresponding gestational age. Chest X-ray can be done as an additional investigation when you want to look for any kind of embolization of these trophoblastic cells. This is just a table. We'll just recap the molar pregnancies and the differences between them. So what is the karyotype of a complete mole? It is diploid, and it can be either 46XX or 46XY, and partial mole is a triploid, so it can be 46XXX, 69XXX, 69XXY, or these or 69XYY. These are very common. Most commonly it is 69XXX. It is triploid. In a complete mole there is no embryo or fetus. In partial mole there is embryo or fetus. In a complete mole there is no fetal erythrocytes. We said, what did we say? It is total avascularity of the chorionic villi. Partial mole, yes. Villus edema in a complete mole is widespread. In a partial mole it is slight. Trophoblastic proliferation also, it is widespread. In a partial mole it is only slight and focal. There is some special investigation which can be done, that is the P57KIP2 immunostaining. This is basically your staining for a particular genetic material when you are performing this test. So it is seen that this P57KIP2 immunostaining is positive in the partial mode. So just remember it as a PPP, partial mole, P57KIP2 positive. Okay, whereas it is negative in the complete mole. And clinical presentation wise, complete mole, yeah, like I said, diagnosis, when you do a scan, you diagnose it as a molar pregnancy itself, but a partial mole can be diagnosed as a missed abortion. The uterine size in a complete mole will be more than the gestational age, but in a partial mole, it can be less than or same like the gestational age, because these fetuses are usually IUGR and not growing properly due to the triploidy status. So they can be either same or they'll be less than the gestational age. Theca lutein cysts in complete moles are common. Partial moles, it is uncommon. Initial HCG levels in complete moles are very high, usually more than 10 to the power of 5, that is more than 1 lakh. Partial mole, there is increase, but it is a slight increase, not as much as your complete moles. Medical complications like we discussed, your hypotoxicosis, respiratory distress, preeclampsia, all that is common in a complete mole, uncommon in partial mole. And one more last important point is the malignant potential, right? Complete mole, there is 15 to 20% chance for a malignancy. In a partial mole, it is 1:5%, less chances of a malignant potential. Okay, so I hope everything is clear so far. Coming to the management part, the management of a molar pregnancy, there is no scope of any medical management. It is a surgical management and it is a suction and evacuation. Okay, suction and evacuation, because you have this molar tissue which is completely occupying the uterine cavity. It has distended it a lot. You have to get rid of it, you have to remove it. And what did we say, one of the complications is it can have hemorrhage. So you want to do it as soon as you can and try to prevent hemorrhage and shock in the patient. So suction evacuation is the best method of surgical management for a molar pregnancy. Best method, it is the surgery of choice for a hydatidiform mole management. Okay, but the management is not management of a molar pregnancy is not complete without your follow-up. Okay, because of the malignant potential of these complete moles and the partial moles to turn into a malignancy. It is very important that this patient, after they have undergone the suction and evacuation, they have a follow-up, strict follow-up, and this follow-up is done with the use of your beta HCG levels. It has to be done every 1 to 2 weeks, right? Every weekly or at least once in 2 weeks until the level becomes normal, right? At least up to 3 consecutive values are normal. Once you have reached the beta HCG level as normal, you don't stop there. You have to follow it up again for another 6 months, but monthly. Okay, this is how you follow it up. Please remember this. It is important for your practicals, MCQs, everything. So the management of a molar pregnancy is not just doing the suction evacuation and getting rid of the molar tissue. You have to follow them up also. You have to explain to the patient the importance of following it up, and that is done by the use of your serum beta HCG. So one point I forgot, because of this, it is very important that before you plan the patient for a suction evacuation, a baseline serum beta HCG has to be obtained. Okay, very important. They may ask you what will be the prerequisite of before you do a suction evacuation. You should say that I want to have a baseline serum beta HCG because I am going to follow up this patient later on and I want to see whether the beta HCG levels are coming down and they are normalizing or not. Okay, and why are we following it up? Because of the malignant potential. So you may ask that if there is a malignant potential, why not do a hysterectomy in itself? You can consider doing hysterectomy in a patient who has completed family. Okay, in a patient who has completed family and who is more than around 40 years of age, you give them an option of doing a hysterectomy after explaining to them the risk of a neoplasia, risk of a malignancy, offer them a hysterectomy. Or suppose you have uncontrolled hemorrhage and perforation during the surgical evacuation, you have no choice but you want to do a hysterectomy. Theca lutein cysts, yes, this is again another important MCQ point. Like I said, these theca lutein cysts can be enlarged very much, right? They can be enlarged to up to more than like 6 centimeters in size. So if you have these cysts and you are performing a hysterectomy or otherwise, whatever, if you have these cysts, then what do you do? How do you treat these cysts? So these cysts should be left undisturbed, right? As such, if you have ovarian cysts, there is so many protocols as to how to manage it. But this theca lutein cyst, they should just be left undisturbed because there is no treatment needed, because upon withdrawal of the hormones, withdrawal of the HCG and the LH effect and the LH stimulating effect, the cysts are known to regress on their own. So there is no need for a special treatment for the theca lutein cysts. But you have to consider prophylactic chemotherapy in few patients. 80% of complete moles regress, whereas 20% of these moles progress to a gestational trophoblastic neoplasia. So what kind of risk factors are there for a patient to develop neoplasia? Advanced maternal age of 40 years, pre-evacuation very high HCG levels of more than 1 lakh, 2 lakh, previous history, if they have had multiple episodes of molar pregnancy, the uterine size was very big, like more than 20 weeks in size. Theca lutein cyst is also very huge, more than 6 centimeters in size. If they have had a respiratory distress following the evacuation because there can be remnant tissues remaining, or they have developed eclampsia, hyperthyroidism, the associated features, then patient has a risk factor for developing a gestational trophoblastic neoplasia. That time it is the methotrexate, right? It is the methotrexate drug, which is a drug of choice for prophylactic chemo, and these are the indications where you want to consider giving methotrexate. That is, if the HCG levels fail to become normal within 56 days. Approximately, the complete moles are approximately, it is seen that the beta HCG levels in the complete moles approximately by 10 to 12 weeks they regress, and around 7 to 9 weeks in partial moles, right? So just remember, if they fail to become normal within 56 days, or there are again rising HCG levels after evacuation or after reaching normal levels, if there has been any kind of post-evacuation heavy vaginal bleeding, or there is evidence of intraperitoneal hemorrhage, meaning it can be an invasive mole, perforating mole, or there can be again remaining molar tissue, if there is evidence of pulmonary, vaginal or vulval metastasis, if there is elevated serum beta HCG even 6 months after evacuation, even though it is still falling. Of course, upon doing histopathology, like I said, that is the gold standard. If upon doing a histopathology, it reveals a choriocarcinoma, then in all these conditions, you want to give the prophylactic chemotherapy with methotrexate. Just a small word on invasive mole, that is also part of your hydatidiform mole. But this has invaded the myometrium as well. Another name for it is chorioadenoma destruens. It is locally very highly invasive, and due to which it can penetrate into the entire myometrium. It can involve the serosa and the adjacent parametrium and the vaginal vault as well. It can progress to choriocarcinoma. It is mainly diagnosed by persistent or rising serum beta HCG following an evacuation and presence of persistent molar tissue on imaging. Thank you.
Docemy.